Good afternoon, everybody. Nice to be here. Let's go down the panel in order. Each of you just introduce yourselves, if you would, for 30 seconds. Then I'm going to ask you to tell us in a minute or two what your particular angle is on this issue, big data, and particularly if there's any pediatric slant to it, if you will. And then we'll go from there. So if you would.
Good afternoon,
Sachin.
everyone. I'm Sachin Jain. I'm Chief Medical Information and Innovation Officer at Merck. I'm also an attending physician at the West Roxbury VA Hospital here in town.
Hi. It feels a little bit like a trick question because yesterday it was 4 seconds or 40 seconds. So
I was told 30.
My
I just.
name is Joy Tobin. I'm the director of the National Patient Safety Partnership with the MITRE Corporation. I'm a former Chief Information Officer and Associate Vice Chancellor for Health Affairs at the University of Illinois.
Thank you, Joy.
I don't think they were picking you up there, Joy. Is she not Mike?
No.
Well, this could be something of a problem. Hold on just a second. I think. Wait a second. There we go.
That's fine. Hi, I'm happy to repeat myself. My name is Joy Tobin. I'm the director of the National Patient Safety Partnership with the MITRE Corporation. I'm a former Chief Information Officer and Associate Vice Chancellor for Health Affairs at the University of Illinois. Thank you.
Thank you. So good afternoon, everybody. My name is Mansoor Khan. I'm the CEO of a company called Alere Analytics. I'm sort of a serial entrepreneur, started a career in aerospace, then in supply chain management, and for the last decade or so I've been working in healthcare with a particular interest in chronic care.
Hello, my name is John Brownstein. I'm on the faculty at Boston Children's Hospital, and I run a research group that essentially does big data analytics called the Computational Epidemiology Group, and we essentially look at novel and non-traditional data sources to understand population health.
My name is Kass-Hout. I'm FDA's first Chief Health Informatics Officer. My background, I'm a cardiologist by training and biostatistician. I had delivered 23 babies when I was in med school, but that's about all I know about pediatrics. But today I want to talk about open FDA and how FDA is really unleashing a lot of data around adverse events for drugs and devices and labeling that would love to kind of see you guys benefit from that.
So let's start with you, Messer, if we could. How big a deal is this? We've all heard about big data. It's daunting. It's the greatest thing since, I would have said sliced bread, but hearing about the pancreatic cancer test, maybe I should update the cliche. How big a deal is it, and how optimistic are you that, from your vantage point, the FDA vantage point, that we're on the cusp of some huge breakthrough, or it's going to take our lifetimes and beyond?
No, I mean, that's a really amazing question. I mean, for us, is when we went live with Open FDA, there was a lot of discussion. Why did we want to do this?
Yeah.
And first and foremost is we want to spur innovation in the research community, spur innovation in the software community around how we can reach consumers to make better decisions about the treatments they're taking, better decisions about the cost of treatments, and also understand when taking a drug or administering a device, there are many others who have experienced the same thing, and wouldn't it be great just to kind of have that information available to you? Also, how this information is all linked together. It's not just about just dumping data there. How a device, for example, the adverse event is linked to something else, like and also like a drug. You understand better about the dosages, understand also about drug-drug interactions, understand better about drug-food interactions, and make those sort of work on those use cases so that researchers can now really take it to the next level and make it really easy to access, because kind of like how the general theme about here is access to data or access to research is blocked behind so many different walls, whether subscription walls or things that you have to overcome, or how can I make it really easy for you to access that information? That's sort of the theme, what really drove us to make Open FDA.
And you are optimistic, wildly optimistic. It's taking longer than we thought. Just a snapshot of that.
Yeah, so some statistics is we went live on June 2nd.
Just this June 2nd?
This June 2nd of 2014 with the adverse events of drugs. Throughout the summer, we release medical adverse events for medical devices. as well as labelings, as well as recalls for food, drug, and medical devices. Data was available in the past, but no one was able to access. And now we have in about 100 hits per second on per node, which means how the information is being accessed worldwide. Over 20,000 systems worldwide connected to OpenFDA. We have 24 apps being developed by the community. And also it's an open source where we have the top 24 developers are not FDA employees, they're actually community developers.
Okay, so John, I ask this of all scientists I meet, where are we on the curve?
Yeah.
That is are we flattening out in this area? Are we just steady progress? Or is this exponential? Are we?
I mean, we're definitely on the beginning points of using this kind of information, both from clinical sphere, but also new types of data streams that we're just beginning to tap into. The whole digital health revolution, where mobile apps and devices are now sort of playing into the big data revolution. From our perspective, we study infectious disease, and it's always a challenge for us to know what's happening in the field. So with the recent emergency of Ebola, to get insights into what's happening internationally, what's happening in the US, we're not necessarily dealing with just the traditional forms of information. We're tying in data coming from mobile platforms, social media, trying to get insights. So even just on the base level, how do we just understand population health status? That already we're just at that point.
So this is the exponential phase of the process. But so Mansur, what do we have to worry about? I mean, I think any number of us are, we've all heard about this, of course, but are somewhat skeptical because we've seen what happens when we try to use our own data devices. Mine was just going off in my pocket here moments ago. Couldn't figure out where the music was coming from. So a perfect example of all the possible glitches here. So are we expecting too much is, I guess, the question I'm asking, in approximate time frame.
So I'm an entrepreneur, innovator. We always expect too much. Right? So that's a given. We're always way ahead of wherever the industry is. If experience is anything to go by, we're going to find a set of relatively specific sorts of opportunities that will result in good results for us. But the big payback is going to take time. In healthcare, it always takes time. So just to give you an idea, right? So there's 5 kind of major areas in which big data is going to have an impact. It's patient behavior, provider behavior, by which I mean right care, right time, outcomes, quality and cost, i.e. value, and then innovations. And if you look at what's predicted as sort of the financial benefit across all 5 of those areas, people talk about anywhere from $300 to $450 billion a year in financial return for the investments we're going to make and the innovations we're going to make.
Wait, just briefly, return how? This is in profits? This is in saved life years?
So it's different for each one of those. In innovations, it could be enhanced revenue, lower costs, better care, better quality of care for the same cost, better life experience for the patients that are going to be. So in each one of those 5 categories, the benefit is somewhat different. But in the end, if you try to reduce it to numbers, it's pretty large numbers. But what's interesting is that it's pretty evenly distributed across all 5 of those. So innovations will return about 1/5 of that. Patient behavior improvements will return 1/5 of that. So, and when you look at those categories, innovations you can do relatively fast. Patient behavior is very hard to change. That's going to take years for us to get the tools that allow us to really change patient behavior. So this is going to play out over, probably the next 10 years, really, if you look at it, to get the full benefit.
10 years to get the full benefit.
The full benefit.
And then does it peak? Then do we have joy? Do we have an S curve, where it goes like that and then plateaus?
I hope it won't. Well, first, can you hear me? Am I live here?
Get as close as you can to that.
Okay. So I'm not sure. I hope it won't take 10 years. I know what we're doing with the National Patient Safety Partnership is trying to harness some of the massive amounts of data that is in many disparate sources and bring that together and start gleaning insights today. So I hope it won't be 10 years. Maybe to get to your full 100%, perhaps it would.
But you're, again, I guess, constitutionally or institutionally optimistic, like Mansur is, right? Because you're doing this now.
Absolutely.
In the private sector.
In the private sector, we are, right. We've started this with 3 pediatric hospitals, and Boston Children's is our flagship of those.
Sachin, do I get a skeptic from you? Any skeptical comments, or are we all going to just go off into the great cloud sunset?
So you look at the title of this session, Predictive Analytics and Big Data. And
yes.
The reality is we're not doing enough with small data, and we're not doing even basic analytics in clinical practice. And this sort of story I always kind of tell about that is a story from my clinical training at the Brigham and Women's Hospital, where a person who worked at the hospital, a hospital operator, came to the emergency room, was in hypertensive urgency. None of us could really figure out what was going on. She was in the hospital for 3 days, and all someone needed to do was actually call down to the pharmacy at the hospital where she actually gets her outpatient scripts filled to realize that she wasn't actually getting her prescriptions filled. And so the reality is we have all of these silos of information and data within healthcare that never kind of connect to each other. And as a result, I think we're missing out on incredible sort of low-hanging fruit to actually improve clinical quality and reduce costs. But we have to look at sort of some of the institutional variables that actually drive the silos. One of the biggest issues right now is health information exchange. People will try to sort of claim that that's a technical problem. That isn't a technical problem. That's a political and business problem. Where we're in a space right now where holding on to patient data is actually a method for preserving patient stickiness and keeping patients within your systems. And hoarding data as a competitive advantage is not pro-patient. It's pro-institution. It's pro-doctor. It's not pro-patient. And so ultimately, I think we have to deal with some of the structural, political, and economic issues before we deal with kind of the sort of frame this as a technical problem. Big data is sort of a, what I think of as sort of a, it's obscuring, frankly, the real issues. It's a term that's obscuring the real issues.
So it's there's a negative externality, as we say in economics, with respect to using or the promise of big data?
Yeah, I wouldn't say that there's a negative externality, but what I would say is that...
A negative side effect.
Yeah, no, what I'm saying is that there's a lot of low-hanging fruit that we're not focusing on. This is a lot of marketing hype to some extent. In the pharma industry, the way I'm always asking the question, big data for what? The way we think about it is sort of three ways. Big data for outcomes research, big data for quality improvement in collaboration with delivery systems and providers. And then the third is big data for payment reform and trying to be able to be reimbursed differently using data as a platform for that. Ultimately, if we can just sort of get the small stuff right, we can then kind of use that as a glide path to do those kind of more advanced uses.
Well, that's the most provocative thing I've heard out of this particular panel. So let's have you guys react to that, if we could, because Joy, any of you, but Joy.
I don't disagree with anything that you've said, but I'm not sure that those are actually big data topics. Those seem like culture.
I don't, and what I'm trying to say is that we hide behind the term big data, is that institutions are kind of talking about predictive analytics. They're not doing basic analytics at the point of care. And so I think that there's really I think we should simultaneously be driving a big data agenda while we're also driving a small data agenda.
Well, so presumably the big data agenda would actually inform the small data and really interacting with the patient at the point of care, because maybe we don't know those things yet. Maybe we don't know all of the discoveries that would actually inform clinical decision support at the point of care.
Let me just sort of be provocative and kind of give sort of a specific example here. So, lots of institutions are investing in big data platforms to predict readmissions. They're doing that sort of instead of doing the simple task of actually just going and looking back at the last 60 days or 90 days and looking back and seeing who are the patients who are readmitted. And that could probably get you the answer almost faster than developing the predictive model and implementing the predictive model, getting clinicians on the front lines to actually use the predictive model. It's creating a lot of work, it's creating a lot of jobs, it's creating a lot of revenue for companies that work in this space. It's not necessarily solving the kind of key problem.
And every one of you is nodding, man, sir.
Yeah. So I agree with that. That's why I said it takes 10 years to get there, right? So we started in real-time decision support, small data, but real-time information to the care provider almost a decade ago. And I swear, this year really is when it's starting to take off, right? So it took a decade for something that everybody's been saying for 20 years is needed and will be great. It took a decade for it to get to the point where you're going to start seeing mass adoption. So Big data, same thing. There'll be very specific applications and solutions, but beyond that, for the kind of mass where you really start to see the value to the health system, it's going to take a while.
John, why does it take so long?
I mean, from my perspective, I think there's a lot of work to be done in terms of methodological development. But I think just to reiterate on Sachin's point, I mean, we're just not even doing a very good job on what I call nowcasting. So
Nowcasting?
Nowcasting. So the current status of my healthcare system, what are the trends that I'm seeing? Just basic descriptive statistics that might help inform care. For instance, we've done analyses where we've shown important findings from just influenza epidemics in Boston Children's ED data, showing the importance of various pediatric age groups as they spread influenza across different demographics. The same being if we looked at the partners' healthcare system, we've seen massive trends in terms of myocardial infarction, and that related to the introduction of Vioxx. But nobody was looking at the data. And that's just, we're not talking prediction here, we're just talking just basic looking at large data sets in very simple ways.
So you're all nodding, you're all saying that that's true, so, but why is it true? I mean, the thing that I was truly amazed by, Sachin, that you said, and I want to know how pervasive it is patient hoarding. I mean, as for an economics reporter, it makes perfect sense that that would be the case, but I had literally never heard the term, certainly, or even contemplated the idea of patient hoarding.
So some of it is that, but there's a real fundamental breakdown in the technologies we have today in getting data. So if you forget about big data, forget about people, when you're dealing with a hospital that's that needs to get you the data, because if you don't provide them the analytics, the small data analytics they need, they're going to get hit by penalties next year. It takes months to get the simplest data out of their system. It's so dirty and so bad. So one area where big data can actually have a near-term impact is this ability to look at our kind of dirty data and extract from it the pieces that we can use to run small data analytics and do very specific things that are going to have positive benefits that are very outsized to the investment.
Todd?
No, I totally agree. I mean, also, what is big data? I mean, big data for us, for example, compared to Facebook, I mean, talking a few million records here is big data for us. But big data to us also is paper, handwritten notes that we receive at FDA, and we have to digitize that. Big data to us is video submitted from smartphones about skin rash or whatnot. So it varies. I mean, it's not just big data because of the volume or the size of that data, but also about the complexity about how you put these pieces together and how you start now generate different questions about the possibilities. Now, one of the things is I always emphasize about big data is about linkages. How can we link this information together? That's more important than the size of that information. As a consumer or as a physician at the point of care, you need the information that's available to you. You need the information that's relevant to that moment to be able to make a decision.
But I'm sitting here and I'm thinking, and I bet there are people out there thinking, gee, maybe big data is just a distraction. It's actually distracting us, and that's where you started here, Sachin.
It's a buzzword.
Distracting us from doing the things that we ought to be doing. You called it the low-hanging fruit. And so it's actually, and that's what I meant by negative or externality, it's like a cost as opposed to a benefit at this point.
So it means what you mean by we, right? So when you talk to a hospital...
I mean you. Yeah, I'm
so
clean.
you go to a hospital in Bronx, right? That's primarily serving Medicare patients. To them, big data means nothing. They're not doing anything in big data. It's not distracting them from anything, right? It's really the cutting-edge institutions and the 300 or so funded startups those are the folks that are really focusing on big data, and they're preparing the groundwork now that over the next 3-5 years will start delivering tools that over the next decade will start having an impact on how care is delivered in the Bronx.
All right, so our panel skeptic responds?
So I'm going to say, I'm sorry to take on this role.
You don't look that sorry.
But I'll wear it strong. So, I think what we're doing, those 300 startups, Dick Foster is on the faculty at Yale, says that he's tracking 2,274 health IT startups. And the reality is that I think most of that's activity and it's not achievement. And I think the question is not about sort of how can I impact clinical outcomes. It's about, how can I IPO my company in 3 to 6 months? And I think we need to start holding our entrepreneurs, holding our institutions, holding our vendors to much higher standards, which is clinical impact now. And I think we have to set a few big picture clinical targets that we want to drive after and go after those. And then let the sort of methods follow the target as opposed to what's happening right now, which is lots of folks at lots of institutions are saying, well, we need a big data strategy, right? And so there's, it's checking a box. It's about, okay, we have somebody working on big data. It's a big data strategy. Instead of saying, let's solve this, this or that problem that this institution faces, and then go after it with whatever tools will work. And sometimes the tools will be small data strategies. Sometimes it will literally be, hiring someone to walk around your hospital and count things. But ultimately, we'll be solving a problem as opposed to setting a strategy without a real kind of vision attached to it. And that's kind of my view of the situation.
All right, so what are we actually achieving, or what are you guys actually achieving now? John, talk about, I don't know, tracking Ebola or for this crowd, the enterovirus, let's say.
Absolutely, and so there's absolutely wealth of information that's coming through channels that we don't generally think of as health-related channels. What people do on social media, on tweet, or on Facebook, or connect on Google searching, that data is feeding into a massive amount of information about health outcomes and health behaviors that can combined tell us something really important and something new that we couldn't get through clinical data. So on the flu example, or the
flu is the obvious one.
We've been building systems that can, say, for instance, tell us what's happening using data from Google, data from Twitter, data even from your cancellation of your open table reservation can tell us actually something very important about what's happening at the community level. With enterovirus, for instance, we run a project. It's a crowdsourcing system that now has people tell us their symptoms on a weekly basis. It's actually small data. It's not big data.
How many people?
About 100,000 people. So you could debate whether that's, in Google numbers that's small, and I guess maybe in patient numbers it's big. But that could tell us at the national scale and even regionally when we hit the peaks of enterovirus and when we were on the downslope. We only found out weeks later from official sources when we were actually out of that epidemic. So these data are actually telling us something very unique and valuable. Even just telling us what's happening right now is extraordinary, and it's very different from what's been traditionally available.
All right, so that's a genuine accomplishment of big or medium-sized data, no?
Yeah, no, absolutely. And I'm sort of, like I said, I'm unfortunately in this. I'm sort of working big data. This is kind of what my role is at Merck. But the way I sort of would kind of push is that John is not interested in sort of big data for big data's sake. John is interested in helping us understand the flu and drive kind of new treatment for the flu. And I bet you he'd use whatever methods he had available because he's interested in actually solving a real problem in the world as opposed to kind of just proving the value of a methodology. And that's what I'm kind of driving here is focusing on the clinical problem as opposed to focusing on the methodology.
Taha, achievements?
Well, I want to achieve, I mean...
it's June. It's only June, so we give you the
great,
10-year time frame. You've only got a couple of months on it.
There's a lot to be done, and also a lot where we can work together. I mean, when you look at the national data from 2012, national hospital data, about 5.9 million discharges, right? It had about 22 million ICD-9 codes associated with them. There were about 90,000 of those adverse reactions to drugs in pediatrics. I'm focused on the pediatrics now.
90,000 adverse reactions to drugs in pediatrics.
Yeah, in 2012. I mean, some of those is poisoning, whether it's accidental or intentional. From medical devices, about 60,000 of those just in 1 year. However, when you look at the data that we have at FDA, I mean, definitely we're seeing the hockey stick. Submissions is on the rise across the board for just worldwide. But if we look in the United States, still we get about 4% of that for pediatrics around adverse events to devices, and less than 20% for drugs. So if we want to make,
So let me see if I, just to clarify. Yeah. So that's the adverse reactions are mainly device-driven, is that what you're saying?
The adverse reactions, no, there's more adverse reactions to drugs than there are devices.
Oh, more to drugs than
FDA, for us at FDA, looking at the open FDA data, and please go to open.fda.gov, you can see the information there. We're only getting 4% of that. When it comes to adverse reactions to drugs. We're only getting to devices. We're only getting about 20% of that when it comes to drugs. So we need how we can work with official sources as well as crowdsource information and see how we can better hear from the consumers about their experiences. Not just companies, not just clinicians. We really need to kind of fill the missing gap.
All right, let me just, I want to open this up to questions. We have about 10 minutes left. Joy, actual tangible achievement?
So we're using big data. We've begun a project, as I mentioned in my introduction, and at MITRE we manage something for the aviation industry around safety. And we use big data analytics, and we take data from multiple different sources, about 165 different sources, and we bring it together and fuse it.
Airlines, airports, and so forth.
Right, black box data, self-reported data, weather data, radar data. And what we do is evaluate it using techniques that we've developed in other industries to see if we can identify what the precursors are to safety events, to prevent them from happening. And it's a very classic application of predictive analytics to big data.
And
so what we're doing now is taking those same lessons that we've learned over the last 8 years very successfully in aviation and applying it to healthcare. So we're taking data from many different sources within Boston Children's initially, including the electronic health record, where we take physician order entry data, medication administration record data. We take data from the pharmacy. We take the CHOOSE scores, and for those of you who practice here know that's the Children's Hospital Early Warning Score, where there's a green light, yellow light, red light evaluation. That's a combination of subjective and objective considerations evaluated every 4 hours on kids. So we take that along with other data from physiologic sources, all the monitors that are on kids. We look at demographics, have the parents, what their education is, what their primary language is. We're bringing that together and studying with very focused questions, to your point, not just applying data analytics for the sake of analytics, but rather looking very specifically at the kinds of unsafe situations that are occurring to prevent harms from happening.
Any discovery you could share?
So we have a few. We're actually very excited, looking at some of my partners here, Dan Nygren, Nina Rauscher, Kathy Jenkins. We're excited. So we set out in February. We started bringing data in from the enterprise data warehouse, and we set a goal for ourselves, which was to identify previously unknown events, and our goal was to identify one this year. And fortunately, the methodology, the data, and the very focused approach that we've taken, we've actually found quite a few things. One would be with physiologic data. They store all of the monitor data on all of the kids for many, many years. And the data had really not been used in this way, and this is big data. And we've looked at that in combinations with the CHOOSE scores, the early warning score. And what we've been able to identify is alarms. We're looking at alarm fatigue. And what we've identified very analytically by unit is that there are quite a few alarms that there are monitors on kids who really don't need them clinically. So it's an opportunity to really look at what the policies are in the hospital, how those are applied, and of course we work very closely with the alarms committee because it's a very complicated process, and we certainly would not want to create new harms. Another area that's been very interesting is in patient identification. So we often talk about the iceberg, the proverbial iceberg, and what we think we know about patient safety, and we kind of intuitively know there's a lot more going on. And through a study of the order entry system, we've been able to very analytically look at logs that people have never looked at before to identify when the wrong patient is chosen in the electronic health record for a medication order, and when those orders are then changed and a new patient is selected. And it's a great opportunity to work with the electronic health record vendor and other patient identification methods that are in place in the units.
So those are tangible achievements, yes?
Actually, I can give you a couple.
Absolutely. This is not, again, I've been painted with a particular
No,
brush.
no, I just wanted a yes.
I accept the paint, yeah. And we have
yes, it's fine.
examples. I mean, one of the things that we're trying to do is better understand the real-world natural history of osteoporosis. Right now, you've got EMR systems that are not linked to bone mineral density systems. If you're able to create that connectivity, you're able to do these real-world studies and understand the natural history of disease. I mean, that's kind of, again, I put that in a low-hanging fruit category. When we had a safety issue that came up with one of our drugs, we were able to query. We've built a number of kind of global data partnerships. We're able to query some of those partnerships to better understand and characterize the nature of the interaction and signal that someone had sort of observed, and actually recognize that the signal was in fact consistent with what we'd seen in clinical trials, which is that there really was no kind of correlation there. And in doing so, we were able to preserve access to a really terrific medication for hundreds of millions of patients around the world. So I think there are real, I think, opportunities here. I guess I'm sort of choosing the contrarian tone because I think that a lot of people get very fired up about these terms without actually recognizing that there are kind of simpler things to do today that could drive the agenda forward.
Can we go to the questions, Mensa? Sure. Yeah. Okay. So questions here with a couple of minutes left. I have. Here we go. Anybody? No. Yes, we got right over there. If we would. It's always that awkward moment before people are willing to ask questions.
I'll try to save you from that. Tom Allard from Boston Children's Hospital. Yesterday we had the panel about mobile health and digital health and all the data that flows through that. Today we have the panel about big data and predictive analytics. One of the points that was raised yesterday was concern about information overload at the point of care. So with all the projects that we're talking about here, with tracking population health, with trying to connect systems that can get them to talk to each other and raise flags, are we potentially adding to information overload for the physician at the bedside, or are we addressing it?
I mean, I can start from our approaches. We went with an approach that's a community approach. So it's not just about open data, it's open data, open source, open community. And the fact there is, we want to kind of respect the fence to, or build the fence to respect, where our boundaries with our neighbors. So basically is build APIs where developers now can develop applications rather than be overwhelmed with the information. And then
APIs?
APIs, application programming interfaces, is basically how software talks to another software to exchange some piece of information. And for us, there were about 24 mobile apps created by the community to address those, exactly that, because before you would have been very overwhelmed, very confused which information you want to get, and information is not linked, and whatnot. But one of the nice things also is about the opportunity for researchers. A lot of now you open the data in ways that researchers can access that, not having to go and submit Freedom of Information Acts against FDA or whatnot, and try to kind of go through that hassle. But rather just kind of look at the trends and the information. The top adverse reaction to drugs is the drug is ineffective. The drug adverse event to a medical device is it's malfunction or injury. And there's a ton of other information that's linked to it. So you can start now ask the right research questions and start kind of peel the onion from there rather than having to find a needle in a haystack.
Just quickly, one word from each, because we're going to run over otherwise.
Yeah, absolutely. We're talking about vast amounts of data coming from many, many different channels. It's all about appropriate design of how that information is represented. I don't think we spend enough time in the research world and clinical world thinking about how to appropriately package information for the clinician and how to integrate data sources into one sort of key insight. So I think we should take lessons from other industries that use much bigger data sets to represent that information back to the clinical practice.
So we've done about a decade of work on this problem of how to display what information and how to get it to the point of care. And one of the key insights we've had is control over the physician, because not everybody needs every piece of data. So giving them the control to turn off things that they don't need and turn on things they need, and that control needs to go down to the patient level. For this patient, I want to see this stuff, but not this stuff. So and that's very doable today.
I think we'll end it there. If people want to come up afterwards and ask you these questions, we're run out of time. Thanks to the panel. Thank you.